Morning, good afternoon, good evening from wherever you're joining us today, and thank you for coming online to hear the webinar. I'm Sue Henshall and I'm the CEO of City Cancer Challenge, and I'll be moderating today's discussion. I want to welcome our panelists. Thank you for joining us. And I also want to make a special welcome to anyone joining us today from CCAN cities around the world, and our health professional communities who have taken time out of their schedules to join us here. I want to talk a little bit about CCAN, if I may. For some of you who don't know about us, City Cancer Challenge, or CCAN, is a global organisation. We support cities around the world as they work to deliver quality cancer care. We work in 9 cities right now in every region of the world, and we will be opening up a call for new cities later in the year. I just wanted to talk a little bit before we start about the importance of communications and keeping the communications channels open. Dr. David Collingridge, the editor of The Lancet Oncology, in his editorial last week, spoke of one of the implications of the COVID pandemic being on the restrictions to dissemination of evidence, to sharing of learnings, to ensuring the cancer community at large is able to inform and respond to evidence-driven data, and to the way we work around this pandemic and how we respond to cancer care in this environment. Today's webinar has been convened in response to the questions and concerns from the CCAN cities that we work with for exactly that reason, to open the communication channels, to share our learnings, and to ensure that you have the information you need to continue to deliver quality cancer care in your cities. I'm very pleased and privileged to introduce to you the 3 panelists today who have joined us. We have Mark Middleton, who is a radiation therapist and CEO of the ICON Group, which provides cancer care to a growing network spanning from regional and metropolitan Australia to New Zealand and through to Asia, in Vietnam, in Singapore, and in China. Mark is also a member of the Board of Directors of City Cancer Challenge. Welcome, Mark. Our second panelist today is Dr. C.S. Pramesh, who is the director of the Tata Memorial Hospital in India, the pioneer cancer hospital in the country, and a leader in cancer research and cancer policy. Dr. Pramesh is also the convener of the National Cancer Grid, a major network of cities, cancer centres across India who provide cancer care. Welcome, Pramesh. And also with us today is Stephanie Dutton. Stephanie is the Vice President and Chief Operating Officer of the UPMC Hillman Cancer Centre, an NCI-designated comprehensive cancer centre in Pittsburgh, Pennsylvania in the United States. Welcome, Stephanie.
Thank you.
Before we get started, just a couple of minor housekeeping. If I could please ask everyone to keep your microphones on mute so that we have the best quality audio for our speakers. We will be recording today's session. We have 500 participants today, and so we want to make sure that the information is disseminated as widely as possible after we finish the webinar. The format today is that our speakers will have around 7 minutes to present to you, and then we'll have around 25 or 30 minutes to do a Q&A session. If you could please put your questions to the CCAN team who are working in the background, and there is a Q&A button at the bottom of your screen, that's how you submit your questions. Also, I just want to remind everyone that we will be conducting today's webinar fully in English. I know there's a number of you who are joining us from Latin America, and just to let you know that there will be another webinar on the 15th of April that will be conducted in Spanish. So, without further ado, I'm going to hand over to Mark Middleton, who's going to talk to us about his experiences across the ICON Group. Thank you, Mark.
Thank you, Sue, and it's a pleasure to have the opportunity to speak to everyone. So wherever you are in the world, thank you for joining us. Thank you to CCAN for the very kind invitation. It's my great honour to join Stephanie and Dr. Pramesh here to speak to you all for this webinar. For those of you who don't know, ICON is an Australian cancer care provider, and as Sue indicated, we've now got services across Australia, New Zealand, Singapore, Hong Kong, China and Vietnam. So we, as an organisation, we've now entered into our third month of dealing with the COVID-19 virus across our network. And as an Australian company, we have learnt an enormous amount from our colleagues in Singapore, Hong Kong and China. So very, very early on at those cancer centres, we realised that what we needed to do was have a response that was truly an ICON response, and not a response that was purely centric to what was occurring in China, what was occurring in Singapore, what was occurring in Hong Kong, what was going to occur, and what we're seeing now in Australia and New Zealand. So very, very early on, as the leader of ICON, I wanted to establish a framework within which we would all operate as an organisation. And I also wanted to keep it very, very simple, because in a situation like this, a crisis, people need clarity of information and they need incredibly regular information. So we landed on something very, very simple. We said to our team, we are going to conduct ourselves during this situation with 3 simple words. And they were calm, connected, and committed. I'm going to outline the 3 of those words for you within the context of what we have done to respond to the current situation. So when I talk about calm, I'm talking about the processes that we put in place to allow our people to continue to deliver cancer care to those people who need it, despite the situation of the virus. So I'm talking about all of the processes that we needed to implement and implement them quickly. Declarations of our staff around their wellness to be at work every day, the screening of patients as they entered our centres, making a really, really quick decision about who could accompany patients to our centres, and the list goes on and on and on. So by taking a very, very calm approach, we were able to lay out systems for our people, no matter where they were in the world. And that's really, really important, because in a situation like this, we have 3,000 staff. They are looking for process and frameworks to work within. Now, within healthcare, we're very, very familiar with those approaches, because that's how we conduct care for the people who need it. What we wanted in this situation was a calm approach to how we were going to look after our people, and therefore, if we can look after our people, we can keep our workforce looking after the patients who really need that care. So everything we did had to be done in a calm manner. And I reinforce that word to our people every single day. I email every single person, 3,000 people in one good morning email every day with that calm message. Then it's about being connected. How do we keep our people connected while this is all going on? While we have people working remotely, our head office in Brisbane, Australia, some 200 people, all of those people are now working from home. We have another office in Melbourne, another 100 people, all working from home. Our office in Beijing has been working from home 2.5 months. For all of you who are working remotely, the first week can be somewhat of a novelty. I can assure you after that, it's not that much fun. So we need to keep those people connected. We need to keep them connected to our organisation and to each other and to our leaders. And that's what we've been doing. Constant communication. The best advice I can give anyone about situations like this is to overcompensate with communication. Stay connected to all of your people. Make sure they know everything that is happening, every process that is being implemented, every single challenge that we're facing, and most of all, be honest and transparent about what is occurring. People want clarity in these situations. There can be no ambiguity. So stay connected, and not just connected to teams, but stay connected to the patients and the people who you are looking after, and the people who desperately need care, no matter what is going on around them. And we've done a whole range of things to stay connected to our patients. Number one, deliver the same great care every single day that we have always done. Number two, we've been providing live Q&As on Facebook with our clinicians around medical oncology during COVID-19, radiation oncology during COVID-19, utilising the expertise of our clinicians to reach as many people as we can. And that's been really, really effective. Each week on a Tuesday morning, I host a live Q&A with all of our staff, with our Director of Research and one of our founding doctors as well. And no question is off limits. We made the decision that we would stay connected with people and we would always be honest and upfront and transparent about what was occurring. Connection is important. People need to feel part of a team more than ever during a pandemic. We need to make sure that continues. The last word I get our team to focus on is committed. We're very fortunate at ICON. Our people have always been committed to delivering great healthcare and looking after people. I am now asking them to do more than ever before. I am asking them to, every day, present themselves for work, every day, sign a declaration that they are fit and healthy for work and ready to treat patients. So every day I'm asking more of our people. I'm also asking them to be on the front line in terms of healthcare and to potentially be exposed to very, very deadly virus. So I'm asking for commitment. And if I'm going to ask for that commitment, I've got to deliver on the other two words. That's calm, all of the things that they need, and connected. We will continue to look after each other, our patients, and ensure that we have a workforce to continue to deliver care, and most of all, be ready to respond after this situation passes, because we know there is going to be a surge of people requiring cancer care after this pandemic passes. So I'm asking people to be committed. I'm not just asking them to be committed at work, I'm urging them to look after themselves outside of work as well, because we do not want people exposed to a virus outside of work and then to bring it into our workplace. The stakes are too high. There are too many people to be looking after. So I'm asking more of our people than ever before. And quite rightly so, they then have the right to ask of their leaders more than ever before. So ultimately, the ICON response is about leadership, and it's leadership from all of our 3,000 people. How do we keep our people safe? We do everything to keep our people safe so that they can continue to deliver care to the patients who need it. So I'll just repeat for you if you want to write this down. It's 3 simple words: calm, connected, committed. Thank you, Sue.
So I thank you, Mark, for sharing that with us. I know that internally we have taken on the calm, connected, committed motto within CCAN as well, and certainly for something for everyone to adopt. We're going to move now to Dr. Pramesh and to Tata Memorial, and to hear about how you've been managing, and also particularly around the delivery of services. Dr. Pramesh, I'll hand this over to you now. Thank you so much.
Thank you, Sue, and thank you for the opportunity. And to all on the webinar, welcome from whichever part of the world you are in. So I have a brief presentation which I will use to are you able to see my screen now?
Yes, we can see the screen. Thank you.
Great. So what I'll do is to cover 2 separate aspects. One is a hospital preparedness point of view, where we look at our own center's response to this pandemic, and on a larger scale of things with the National Cancer Grid guidelines on how we have suggested modifications of cancer treatment because of the COVID pandemic. So the consequences of the COVID-19 pandemic are apparent to all. It's resulted in a shortage of supplies, mostly with masks and other personal protective equipment in hospitals. And this is a global phenomenon, not just restricted to countries like India. There's also been a shortage of hospital personnel for various reasons. Some because they are high risk and needed to be spared from routine clinical duties, some because of quarantine, either because of travel or having been exposed to a person who's suspected or proven to have COVID-19, and more recently a national lockdown that's been announced in India and in several other parts of the world as well. There's also in some parts of the world shortage of ventilators, beds, and basically hospital infrastructure. So there's a need to realign your priorities on what to treat and in what priority. And finally, all this with a desire to maintain physical distancing, both amongst the staff as well as the patients. And sometimes this is not so easy in a busy hospital like ours. So I don't think there's a straight answer to what should be the modifications in cancer treatment during the COVID-19 pandemic. And if you're looking for a off-the-shelf recipe, I don't think that is possible. It needs to be individualized basis the institution as well as to the individual patient, and therefore cannot be prescriptive. However, what I'll describe are some basic principles, and these are decided based on what stage of the pandemic your country is in or your region is in, and what the likely trajectory of the pandemic is going to be over the next few weeks. And often we don't have the right assumptions which drive these models to predict the trajectory. It also depends on the infrastructure available at the hospital and how overwhelmed you are by treating COVID-19 patients. We are a pure cancer hospital. Nevertheless, we have been asked to be in readiness to treat patients without cancer, but who have COVID-19 as well. And finally, the decision also depends on the risk of developing COVID-19 and its resultant complications to the patient versus the risk of getting a suboptimal treatment for the cancer itself. So what I'll share with you is a document which we are in the process of releasing in the next couple of days, which are the National Cancer Grid Guidelines for the delivery of cancer care during COVID-19. And just for those of you who are not familiar with it, this is a large network of 200 plus cancer centers across India, which between them treat over 700,000 new patients with cancer, which is approximately 60% of all of India's cancer burden. So as I mentioned, the general principles remain that we need to try and reduce the risk to patients, reduce the healthcare resource utilization because we never know what's required in the next few weeks, the identification of suspected cases as well as proven cases, and to reduce the risk to the healthcare provider. So we break this down primarily into a few measures, the first being infection control measures. These are general principles applicable to all areas: hand hygiene, social distancing, and cough etiquette, and to avoid overcrowding by rescheduling follow-up visits and increasingly teleconsults to replace the physical clinic visits. So this is something that we instituted earlier in March, which was screening all patients who come to the hospital for symptoms suggestive of COVID-19, redirecting so that patients with suspected or proven COVID are not mixed with the remaining patients, calling only family members for medicine refill or arranging a direct delivery, telephonic follow-up for compliance, and fast-tracking consults within the outpatient area. With the staff, we've taken several measures, which include identification of those at risk, staff sparing measures. So for example, at any given point of time, half our staff work from home. Therefore, in case there is a need to have a mass quarantine of people, of staff who are at work, we have spare staff to fall back upon. There's been several activities which have been identified which could be done from home, like data entry, research, and so on. And a very important part of our efforts have been to train our staff on infection control measures, appropriate use of masks, gloves, and PPE, which cause a lot of anxiety amongst our employees, as well as waste disposal. So as I mentioned, there's no one size fits all, and I've already described the principles based on which we suggest that treatment be tailored. And I found this recent publication from Tim Hanna and his colleagues at Queen's University, Kingston, very useful in prioritizing what should be offered. And if you see at the bottom left of the screen, you have options where alternative treatments exist or delays which doesn't affect the outcomes. And as you go up, the higher priorities are those which require imminent risk of early mortality, like, for example, acute leukemias and aggressive lymphoma. So this is quite a useful approach to take, and that's exactly what we've done with the National Cancer Grid Guidelines as well. So I'll just very briefly speak about surgery, medical, and radiation oncology. With surgery, as is obvious, emergency procedures to be given priority. Cancer surgery is not considered elective. Therefore, to defer all kinds of cancer surgery would not really be advisable unless the situation reaches a point where all hospital resources need to be diverted towards COVID treatment. But I can't overemphasize the need for careful case selection. Patients with multiple comorbidities do particularly badly with any form of treatment for cancer in the face of the pandemic. And these are patients we would be very reluctant to treat with very intensive treatment. So we divide this into 3 phases depending on what stage of the pandemic we are in. And the earliest phase, which is the phase 1, is a semi-urgent setting where it's a kind of a preparatory phase where practically everything except a lot of cancer surgeries continues to be performed because the results of surgery are so much superior to other forms of treatment. But if there are alternatives which exist, like for example, stereotactic body radiotherapy for early lung cancer, we would opt for those rather than for surgery. As we move on into a more urgent setting into phase 2, where limited hospital resources are stretched, we would be far more selective, and only those which are semi-emergent, like nearly obstructed GI cancers and all emergencies, would be prioritized over those which are more elective. And finally, when we enter phase 3, and I hope many of our countries don't ever reach this phase, where all hospital resources are diverted for COVID-19 patients, surgery for cancer remains restricted only to real emergencies, and where sepsis is a major concern, with all other cases getting deferred. Similarly, with radiation, several efforts to avoid crowding in outpatient clinics, appointments of patients being staggered, clinical review being combined while they're awaiting treatment or their radiation, and or telephonically to avoid crowding in the outpatient clinics, onboard imaging to be minimized, hypofractionated schedules in areas where they are proven to be beneficial, for example, in breast, prostate, and lung cancer. And when it comes to palliative radiotherapy, especially when it's done for emergency situations, to be delivered in single fraction or weekly fractionation. So it's good to prioritize, use another measure by categorizing patients into those which are rapidly proliferating, like lymphomas, head and neck, and lung cancers, and those which are relatively less aggressive, like breast and prostate, as category 2. And this is similar to the earlier step ladder pattern that I mentioned and showed in the earlier slide. And prioritizing, for example, the top priority would be given for radical curative intent radiation, where especially for category 1 tumors, and the least priority would be offered for adjuvant radiation if R0 resection has already been done, and there is less than a 20% risk of local recurrence at 10 years. So this is more a question of allocating resources optimally. And similarly with chemotherapy, minimizing harm, use of alternative, less myelosuppressive chemotherapy, like single agent or fewer drugs, lesser frequency, switching to oral options, omitting maintenance in some solid tumors, liberal use of colony stimulating factors, and limiting the dose and duration of steroids. And similar to the radiation and the surgical prioritization, prioritizing curative intent therapy in hematological malignancies as top priority, and stem cell transplants as the lowest priority. I'll very briefly mention the hospital level preparedness, and this was recently published just yesterday, and it's available free online. I'll just summarize what we've done at the hospital. Employee directed initiatives, and as Mark said, I think the single most important emphasis would be on very open, transparent communication, and this is key to getting complete cooperation from all the staff within the hospital. The next step we did was to lay off high-risk employees. By these are elderly, those with multiple comorbidities, those on immunosuppressants, and as I mentioned, the staff sparing, so that in case of a mass quarantine, we have staff to fall back upon. The patient-directed initiatives are primarily to reduce crowds in the clinic, screening stations outside the hospital so that suspected or proven COVID patients are screened outside and are not allowed to mix along with other patients who are on therapy, and an increasing reliance on teleconsults. From a hospital point of view, we've prepared SOPs for practically every single COVID-related eventuality. Fever clinics being started, where again, admixing of patients with fever and those suspected with COVID-19 is not permitted with the other patients getting treatment. A separate isolation ward where patients are admitted pending results from COVID-19 testing, which we've started very recently at our own hospital. And the more recent national lockdown, which necessitated some pretty unconventional methods that we had to institute, including transporting staff from their homes to the hospital, patients who could be discharged getting assisted with their transportation as well as with their food. and the actual creation of some parts of the hospital, converting the hospital into a hotel where patients and staff could be accommodated to ensure that we had a critical mass of employees being present at the hospital. We encountered multiple supply chain disruptions, and especially with the last mile transport with the lockdown, we actually had to send a lot of our hospital vehicles to pick up supplies that we needed, especially materials like masks and PPEs. And we also used this opportunity to have group negotiations for masks and PPEs so that we could get them all together and then distribute it amongst our different hospitals. We did use this opportunity for research to look at and evaluate low-cost ventilators. This was in partnership with some industry partners. And we're also looking at seeing how we could reuse PPEs so that they are more optimally used. And finally, as Sue mentioned, a very important part of our activities is dissemination to all the National Cancer Grid centers and beyond, even to centers which don't treat cancer. And these are in the form of the NCG guidelines, as well as regular webinars that we hold on this. So I'll leave these references with you, which I found very useful as we went through this exercise of formulating the NCG guidelines for cancer treatment, as well as a hospital preparedness list as well. So I'm happy to share these slides, and you could have ready access to them. So I'll stop with that, and we'll probably take questions towards the end. Thank you.
Thank you, Pramesh, so much. And we will be able to share those slides with you after the webinar, as well as the recording. For those of you who have just joined us, we have just heard from Dr. Pramesh, the director of the Tata Memorial Hospital in Mumbai in India. And we've also heard from Mark Middleton, the CEO of the ICON Group. We're going to move now to the United States, to Pittsburgh and the UPMC Hillman Cancer Center. And Stephanie, if you would like to share with us your experiences so far and the learnings that you're taking right now.
So from our perspective, as Sue said, with UPMC Hillman Cancer Center here in Pittsburgh, Pennsylvania, and I'd first like to thank the organization for including UPMC in this very informative chat. I'd like to also thank my two colleagues, Mark and Pramesh, for very informative information that you've shared about your strategies and how you're approaching this. So UPMC, obviously here based in Pittsburgh, Pennsylvania, we have 70 cancer center locations across the state of Pennsylvania. Uniquely, we also have a location that's up in New York, which in the United States, New York is a high prevalence COVID state right now. We also have a location in Ohio and also one in Maryland. So we do touch multiple different states, which has actually created some interesting challenges for us as we implement various different process and policy to address the outbreak of COVID. I would mirror much of what my colleagues have said, and we'll try not to repeat these things, but I think engagement is very critical. Engagement and early engagement with all stakeholders within your organization is going to be very critical. Everything from engaging the physicians within your practice and ensuring that the physicians are very well informed in regards to how we're managing moving through COVID, and also how we're preparing not only our physicians and our staff to manage through, but also our patients and their families. Working with staff very closely, we've had to learn very quickly, how do we move more people to work from home types of settings versus coming into the office. And in some cases, that's even infrastructure challenges. How large is the bandwidth for folks to be on your network? Do people have computers at home? I mean, we've packed up people's laptops and people's desktops and monitors and just allowed them to take them home so that they were able to connect. We've also been challenged with, in some of our more rural sites, folks that don't have internet at home. So, you know, you're suddenly trying to figure out how do you manage through that. But minimizing the number of staff that we have coming into the facilities, not only to share and protect the staff that we may need later in the pandemic, but also to minimize those staff coming into the centers who may be actually infecting others. Family members and patients have been, you know, obviously over communicating with our patients. In most cases, everything that we've implemented, patients seemingly have been very appreciative of the fact that we're paying attention to this and that we are trying to put things in place to keep them safe in our facilities and to keep our staff safe. One of the things that was very difficult is when we implemented the no visitor policy. That's very difficult with cancer patients. As many of you know, cancer patients rely on their family to be with them during their treatment. And I've always said to our team, you know, a cancer diagnosis doesn't just happen to the patient. It happens to the entire family unit. It happens to their social network. You know, people wrap around that patient. They want to be present. They want to be in the cancer center. They want to be able to help them through their treatments. And at this time, we're limiting those visitors so that they're not allowed to come in. We've had to put things in place like FaceTime and Zoom, like we're doing today, and things like that, so that family members can stay connected to their loved one while they're receiving treatment. All of our vendors, you know, even considering how do you limit your vendors coming in and out? We do need those deliveries. We need people to come in and work on our equipment, things like that. But how do we limit those vendors? How do we manage those vendors so they're not coming in during high prevalence hours of patient care? And that's really changed, you know, how we're managing even within the cancer center locations. One thing that I think, and I tell my team this every day, is that during this pandemic, we've learned, and it's kind of an interesting term, but we've learned to pivot very quickly. You know, as you begin in the pandemic, there are things that you're thinking about and doing, and you know, then things change. The requirements change. Your screening changes. You know, some of our screening changed because of availability of PPE. We've heard both from Mark and Pramesh that PPE has been very difficult through this pandemic. As PPE increased and we had more access to surgical masks, we had to pivot because now we are screening every single patient and every staff member at our front door. We're providing every patient and every staff member and those few visitors that we have masks at the front door, and we are encouraging them to wear them while they are in throughout their visit and while they're here in the cancer center, not only to protect themselves but to protect each other. You know, those types of changes. And when you implement those changes, you have to do it very, very quickly. And it's important that your team is communicated with, and you are clearly transparent when those changes have to happen. Again, I've talked about working from home. I think the other thing that's been very challenging is, just like we're doing today, we're doing a video conference. You know, I can't tell you the last time I was actually in a meeting with people in a room. We just don't do that anymore right now. You know, everything is video conference, trying to keep everyone safe, being able to have videos so that you can actually see each other and you can actually interact, I think is very important. I also do a daily huddle with our entire cancer center group. It's a 30-minute huddle. It just gives me the opportunity to update people, let people know what's going on, let our staff know what's going on, our physicians, if there have been any changes in terms of our process. But that's been very, very helpful. And I think it's keeping people informed about what our initiatives are and how we're managing through this. The last thing I would say, and just something that I think it's been touched on, but you know, you have to almost begin thinking about how would you handle a site closure? How would you handle consolidations of locations? We have 70 locations across those 4 states that I mentioned earlier. We have had to close one site for a quarantine period right now, and that was a quick closure. You know, we did it on a Friday. We closed the facility by end of day on a Friday because we had a small cluster at that location. It's a difficult thing to do. You're looking at moving patients, you're putting staff in their home environments, some of which don't have the technology that I mentioned earlier. You're changing communications, you're communicating very quickly to not only the state that you're in, but also the hospital systems you might be associated with. So it's not something that you typically think through. You know, we all think through, how do you open a new location? How do you prepare for a new location to open? There's usually a long window of time that you're planning and preparing for that opening. But when you're closing a location because of the pandemic and you're closing for a quarantine period, you're generally doing that very quickly. So I would encourage people to be thinking about that. It's kind of the worst case, but you do need to be prepared for that. The other thing that we've spent a little bit of time on is how would you begin consolidating centers if you needed to? And as Pramesh identified, how do you move to a center that perhaps is treating all COVID positive patients? if you need to go to that extreme. But I think all of that pre-planning will help us if we need to move in that direction. We have not had to go there yet in terms of a location that's dedicated to treating COVID positive patients. But we are prepared if we need to move in that direction. So I will stop there. I know we have a lot of people probably wanting to ask questions. Again, thank you for inviting UPMC to participate, and I look forward to hearing what folks are thinking.
Thank you so much, Stephanie. And thank you to all of our panelists. We're going to move now to a Q&A. Many of you have been sending questions in from all corners of the world. So I'm going to direct questions to our panelists and allow each of you to address them. And please let me know by a signal if you have something to add. So the first question to Mark, one of the concerns that people have raised consistently is around supply chain and how to manage the issues of supply chain in this environment.
Yeah, well, it's a really tough, it's a tough question, and I think both Stephanie and Pramesh have touched on it as well. PPE is at an absolute premium. Everyone wants it to do the same thing that we all want to do, is protect our people so that they can look after people and continue delivering care. From the ICON perspective, I guess, again, we were somewhat fortunate that we're now into over month 3 of responding to this because of our China locations, our Singapore locations, our Hong Kong locations. Now, we had to be very inventive to get PPE to some of those sites, including shipping PPE from Australia into China. And there were times we had to get extremely inventive to make that work, but we did. We were able to supply Singapore out of Indonesia, and now we're supplying Australia back out of China and Indonesia and Singapore as well. What I would say to everyone around supply is one thing. The first point, though, is what do you need and how are you going to deploy that PPE? I think that you know, sometimes in a crisis, our first reaction is to, okay, let's do this and do it immediately and put everyone in PPE, which means you're going to burn up your resources very quickly. What we've done at ICON is we've got a very robust PPE plan, and it's a strategy, and it's based on science about when our people need to put PPE on, and then how do we roll out from there. And not every centre is activated at the same time, because differences in locations and differences in the rates of community transmission. So look, what I would suggest to everyone is with supply, you need to look under every rock. You need to explore every single avenue. We've had many contacts reaching out to us by so many different individuals within ICON, and many of them have actually come to fruition with shipments of PPE. So what I would do is be exploring every single avenue. Not all of them will work, not all of them will come off, but some of them will, and that's how you need to go about it. I'd also suggest that all of you who are in healthcare around the world, reach out to all of your contacts. We've had many partner organisations reach out to us because we have centres in China, and we've been able to direct them to suppliers in China that perhaps they haven't interacted with before, or perhaps they haven't heard of before, or what is happening even more frequently is that they're actually new suppliers as well. So what I'd suggest with everyone with supply, there is no perfect answer. Do anything you can to find it, then make sure you use it very judiciously.
Thank you, Mark. If Pramesh or Stephanie, if there's anything you'd like to add, otherwise I will ask Pramesh. We're having a question here actually from a number of our cities around palliative care. Obviously you talked about a lot of delivery of services, but are there specific areas that people should be thinking about in terms of delivery of palliative care? Have you changed your policies during this time? And what are the priorities for palliative care for your patients?
Yeah, that's a great question. And we've actually had the need for supportive care increase quite dramatically during this pandemic. Some of it is partly because there were these borderline indications where therapy would have been given minus the pandemic, actually now going in for supportive care because the margin of benefit wasn't considered strong enough to offer systemic therapy. And therefore, the demands on palliative care have gone up significantly. And this is why I completely agree with Stephanie when she said that we need to be very nimble and flexible with our approach. So we actually had to deploy a number of our other clinicians, doubling up to provide supportive care to support the existing palliative care department, because they would by themselves not have been able to meet the demands, rising demands of palliative care. One thing we've done is we've stopped our home care services. And this was a deliberate decision, primarily because a lot of our patients lived in areas which were pretty crowded, and we didn't want to expose our staff to potential infection in those areas. And therefore, we took a calculated decision to stop the home care services and replace those with teleconsults. What we've done is to actually offer home care in a slightly different model by doing a teleconsult, and if they needed medicines or morphine, for example, those were transported across to them rather than allow them to come to the hospital just to procure care. So there have been a few tweaks that we've needed to do as far as palliative care is concerned. And so I'm assuming that this number will only keep rising as we see an increasing upsurge with the pandemic itself.
Pramesh. Stephanie, we've had a question from our colleagues in Paraguay regarding treatment adherence. Not something that perhaps immediately comes to mind, but certainly they're raising it as an issue, and perhaps you could give them some guidance.
There you go. What I would speak to is the fact that, we've had to actually rely on our physicians, rightfully so, to help us from an administrative perspective to identify which patients could safely be delayed in their treatment, which patients could be maybe on a slightly different cycle in terms of their treatments. And I know when we're speaking of treatment adherence, obviously we want to make sure that patients stay compliant with their treatment protocols and with their chemotherapy regimens. But in the state of pandemic, you're looking at opportunities that, again, you can safely minimize the number of patients that are coming into a variety of your cancer center locations. Pramesh just mentioned the concept of telemedicine and keeping video visits, bringing video visits up and live. I think that's something that, again, I would encourage everyone who's participating in this to really be looking at what your resources look like around telemedicine, and how do you stay connected with your patients. Perhaps they're on an oral chemotherapy regimen. You don't have that same ability for that patient to come in and see you and be able to evaluate that particular regimen and their tolerance of that regimen, but the video visits will certainly allow you to stay connected with that patient. One thing that I know here at UPMC was very important to us is that we didn't lose sight of those patients. If we had a patient who we were safely delaying their treatment for a particular reason, we didn't want that patient to get lost. We didn't want that patient to feel like, okay, now I'm being socially isolated because of the pandemic. I'm being asked not to come into the cancer center where, quite honestly, I've always felt very comfortable and wrapped around, as I would say, with the nurses and the staff that get to know those patients very, very well. Now I'm being socially isolated in my home. How do I stay connected? How do I know that I'm doing the right thing? How do I know that I'm continuing to get the treatment and being monitored the way I need to be monitored with a cancer diagnosis? Again, I think those telemedicine visits are extremely important, but looking at your resources, we here at UPMC, we had to look at things like how many cameras do we have deployed? How many laptops do we have our physicians deployed? What technology can a patient access to be able to allow them to participate in a video conference? Is it something like FaceTime? Is it Zoom? Is it, Teams? Is it any number of various different platforms? But cancer patients, I don't think are used to that kind of interaction with their provider. They're used to coming in and having that, more intimate interaction with their provider. So moving more of those to telemedicine, monitoring their cancer treatment via telemedicine, and monitoring their adherence to those therapies that they can continue to participate in at home. And then also those patients who the physicians have deemed, no, it's important for that patient to come in and receive their treatment, whether it's a radiation treatment or a chemo treatment. Again, working very closely with the doctor to ensure that we're bringing those patients in safely and that they are continuing with their treatments.
Thank you so much, Stephanie. I'm going to move back to Mark now because we're having a number of questions being asked. I think it was raised earlier in the discussion around the particular issues associated with screening. I just wondered if perhaps you could share how it's being managed at ICON.
Yeah, thanks very much, Sue. Look, I think screening is obviously a critical component of what we need to do to ensure, again, that our staff are safe and that we can continue to deliver care to patients. It's really the first line of defence. If you can stop people coming into your centres who may have COVID-19, well, that's going to protect your staff. So what we've been doing for a long time now is, patients have already been contacted via SMS much earlier than them actually visiting the centres, to remind them of all the screening procedures that we've put in place, and also the exclusion criteria, patients and visitors, and that's really, really important. As I mentioned earlier, we've asked patients not to bring a support person to treatment. If they need to, there can only be one, and that certainly can't be anyone who's under the age of 16 years. So, and everyone in that centre must adhere to strict physical distancing. We've got lots of communication outside all of the centres alerting anyone if they've got respiratory system symptoms, please don't enter. And anyone who enters our sites is screened for any travel or COVID contact risk factors. And our screening includes temperature checking as community infection rates have risen, and also following what each relevant government has been saying. And I think one thing I really want to come back to that Stephanie touched on is the speed at which you must make decisions in this type of situation, because quite literally things are changing not just daily, they're changing hourly in some circumstances, and we have to make decisions in a very, very rapid sense. And that means you don't always make things happen perfectly. And speed for us beats perfection, and we have to keep that in mind. All patients are screened at the entrance to our centres, and if they meet any of the exclusion criteria, they're moved to an isolation room. That's where they're clinically assessed. One overarching guiding principle for all of us at ICON, that no one with an undiagnosed upper respiratory symptom can enter our centres. It doesn't mean we won't treat a patient who has a cold, but we do need to have a confirmed diagnosis to follow the appropriate precautions. And then, of course, we have, following that, all of the PPE protocols that I've talked about, and all of our staff have been appropriately trained to use PPE appropriately. And I've got to really stress that. It's one thing to have PPE, but we need to make sure our staff are trained appropriately. I think there's a lot of stories that come out of China, and we will continue to see coming out of China, where perhaps PPE hasn't been used properly and it has had tragic results. So that's really the way we approach screening, and I'm sure at many cancer centres around the world, it's exactly the same, depending on that community transmission rate and what we need to do to keep our people safe.
Thank you so much, Mark. And really along that line of working with patients and their families, Pramesh, you talked a lot about prioritization of cases in your presentation. More generally, we're getting questions about, how do you manage patients and their families, their expectations, if in terms of working through that prioritization and helping people understand how important that is?
I think this is again an excellent question, and it's a really tough one as well. Unlike other hospitals, because we treat only cancer, the priorities of a patient with cancer, even in the face of this pandemic, remains the cancer treatment. Our patients are not really as worried about developing or getting infected by the COVID virus as much as they are of their cancer treatment being suboptimal. So it's been a pretty tough job of having to prioritize, and the kind of decisions that we have been forced to make under these circumstances. I would only say that it's a lot of shared decision making that goes into this, and being completely open and transparent with patients about the reasons behind those tough choices, which some of them are able to understand, not all of them. We've also been fairly aggressive with continuing treatment where the margin of benefit has been substantial. So for example, I treat thoracic cancer. So if I had an early esophageal cancer, I would continue and go ahead with surgical resection or with neoadjuvant therapy followed by resection, primarily because the results are so much superior to any alternative form of therapy. On the other hand, if you had a lung cancer which did not have any of the mutations which lend itself to targeted therapy, and the actual survival benefit you're looking at is a question of 6 to 8 weeks additional with the use of systemic therapy, that's when we would probably scale down on the therapy and either give a lower dose or a single agent or something which wherein you minimize the possibility of the patient developing COVID, and if they develop COVID, reduce the complications of doing so. But I think the key here has been very open communication and transparency with patients as to the reasons why we are making the choices that we need to make now.
Thank you, Pramesh. And Stephanie, I want to follow that up because you were talking about the level of communication that's been put in place amongst your health professionals. In terms of new guidelines, prioritization, these sorts of issues, how are you managing to communicate to your health professional groups? And also, given Mark was saying things are moving so quickly, things may change on almost a day-to-day basis.
It's very true, Sue. And I think one of the things that we all need to understand is that the way we deliver cancer care and healthcare, the way we delivered it 6 months ago is very different than the way we're delivering that care today. It is being able to pivot quickly. It is being able to ensure that you're communicating with your team, with all of your employees. UPMC has 90,000 employees across the entire system. Now that's not all Cancer Center. Cancer Center is very similar to Mark. We're about 2,500, 3,000 employees across our Cancer Center network. But it's ensuring that we're answering their questions, we're communicating with them, that we are being as transparent as we possibly can, and working very closely with our physician leaders, because there are physician leaders in every one of our Cancer Center locations who really need to be the conduit of some of that, how we're changing care delivery, how we're making some of those decisions around whether a patient needs to come in for their treatment, or perhaps we're going to change their treatment a little bit so we minimize the number of visits that particular patient needs to come in. As Mark said earlier, looking at hypofractionation and some of the radiation oncology regimens, limiting the number of treatment times that patient needs to come into the center. But I think it's really over communicating. We're changing something that, our care delivery model that people have been very comfortable with for a long, long time. I mean, you have nurses that are very comfortable seeing their patient come in and sitting with them and talking to them and being face-to-face with them and comforting them. And we're really changing how that care is being delivered as we move more into the social distancing and limiting the number of patients that are actually in our cancer centers at any given time, stretching out the day in some cases so that we're not clustering patients in the treatment room or in the waiting rooms. As Mark said earlier, trying to screen every single patient and employee that comes in, that's very different than what we're used to. We're used to patients walking in and, someone greeting them and helping them get to their location within the cancer center for their treatment to begin. So, we have put a lot of change in place, and it's important that we continue to educate not only our staff and our providers, but also our patients and their families in regards to why we're making these changes, and the fact that these changes really are designed to keep them safe and to keep their caregivers safe.
Thank you so much. And I want to open this question up to the floor. We've got a number of our cities asking about any particular concerns around pediatric cancers and working with children. Is there any advice that anyone would be able to provide to our participants?
Well, I can speak from the UPMC's perspective. I mean, we do have obviously a children's hospital here in Pittsburgh, and they have put many of these very same parameters and precautions in place to protect the pediatric population. Obviously, we also have a very strong women's hospital that has had to put in place things around the labor and delivery process and how many family members. I mean, that's always such a celebratory event for a woman to be having a baby and to have, you know, their entire family, their spouse and their mother-in-law and everyone else in the room or available in the hospital when those events are happening. And you know, now very similar to the cancer center, they're limiting the number of people that can be in the room, really looking more at using different technologies for people to be able to celebrate in that. But from a pediatric perspective, I think, you know, it requires the same amount of diligence that it does in the cancer center, and to ensure that we're monitoring those patients very, very closely and putting in some of the same safeguards that we do in any other cancer center location.
Ramesh, did you want to make a comment?
Right. So I just wanted to add to what Stephanie just said, that pediatric cancers are probably the area where we've scaled down cancer services the least.
Mm-hmm.
A couple of reasons. One, for some fortunate reason, the susceptibility of children to develop COVID seems to be lower than for adults. And more importantly, the results of cancer treatment are so much superior in children that we are prepared to be a lot more aggressive in continuing with therapy than we would be with a very elderly individual with multiple comorbidities. So that's the only bright spark I see in this whole story, that we've been able to provide almost complete pediatric cancer services to our patients.
Thank you both. So I think we only have a few minutes left. I wondered if there was any points that any of you would like to raise that we haven't covered. Some of the questions that we're getting from the people out there who are on the webinar is really about, particularly when you're dealing with such wide networks of cancer centers. Each of you actually are part of large networks. Within those networks, you have very different population groups, different demographics. Is there anything with regards working with those very different groups that you've had to put in place quickly, as you said, to pivot, to manage different populations within your network?
Yeah.
Well, so you go, Stephanie, after you.
One thing I would say is one of the populations that we really had to make what I would refer to as a quick pivot on are those populations that are most vulnerable, even within the general vulnerability of cancer patients. But I'm really talking about patients like stem cell transplant patients and you know, complex immunotherapy patients. Again, physician leaders took a look at how can we manage stem cell transplant patients, because in many cases they are in the hospital for, you know, a prolonged period of time during that transplant. And is that, you know, you're taking that type of patient, you're taking their immune system, you know, really down to zero, and then bringing them back with the transplant. So our physicians have looked very closely at that, and also working with the national organizations wrapped around stem cell transplant. And we have taken a look at moving some of those patients out so that we're not proceeding with a stem cell transplant. If we can delay that safely, clinically and safely, if we can delay that a little bit. So, you know, that's definitely a higher vulnerable population that we had to look at very quickly. Same thing with the CAR T patients and some of the higher end immunotherapy patients. Again, we're still providing those services, but if it's something that we can look at delaying a little bit from a patient safety perspective, we are looking at those on a case-by-case basis.
Right, thanks. Mark, did you want to add something?
Yeah, no, thank you. So, look, slightly different example. I just wanted to show how quickly you might have to pivot in some of those situations in Singapore and in Hong Kong at our ICON centres. You know, large percentages of our patients come from outside of those countries. So they're coming from other parts of Southeast Asia, and in Hong Kong's case from mainland China. Now, the governments of Hong Kong and Singapore shut those borders. So we had very, very little time to respond to that. What that meant was there were some patients who had to go home to their own countries halfway through a course of chemotherapy, for example. Now, we had to pivot very, very quickly and work with partner hospitals in their home countries, connect our doctors via telemedicine to continue to oversee that treatment and care. So the level of disruption to a service, not just a service, to a patient's life, is immense, and we need to respond very, very quickly. Now, fortunately, we've been able to do that, but without telemedicine, without partner hospitals, it would have been very, very dire circumstances for those patients. And I think that's just an example of having to respond very quickly and in ways we've never had to before.
Thank you so much. Unfortunately, we're out of time. I want to thank each of our panelists very much for joining us today. There was an incredible amount of information shared. As I said at the beginning, the webinar has been recorded and we'll be making it accessible through CCAN over the next couple of days. I just wanted to close as well as thanking everyone for joining, especially, as I said at the beginning, our representatives from our CCAN cities. But to leave on the note is what I heard very clearly is transparency, clarity, and agility. These are the things that we all need to embrace, whatever we're doing with patients, with our health professional communities, or even just sharing evidence and information. Make sure it's clear, make sure it's transparent, and make sure that it really is responding to the needs of those who are asking the questions. So thank you again for joining us, and we hope this is the first of a series that CCAN will bring you over the next few months. As I said, our next one will be in Spanish on April 15, where a couple of our key network partners in Barcelona oncology centers will be providing their experiences, and particularly as they are in the midst of the epidemic right now in Spain. Thank you again, and good evening, good afternoon, and good morning. Have a lovely day, everyone.
Thank you.
Everyone. Thank
you, and stay safe, everyone.